So I'm going to talk to you about some current trends and controversies in biologics, and I want to skip ahead to this slide right here just for a second and go back to that conversation that we just kind of had. You know, fusions have a really bad name. Okay, so nobody wants a fusion. They're kind of like divorces. Nobody wants a divorce, and nobody should ever get a divorce. But unfortunately, 50% of people do because they're a necessary evil. Some people are better off divorced than they are staying together. And some people need a fusion or they're going to suffer for the rest of their lives. And fusions do a lot of good. So it's just, you know, it's the way it is. So backing up now, there's a lot of biologic options for fusions. There's cancellous allograft, demineralized bone matrix, platelet gels, allograft cells, ceramics, BMP, and there's a lot of controversy as to which ones are better. So going back to the fusion, it's important from a whole host of reasons, but there's a lot we could talk about fusions all day, but there is an association with increased axial pain, worse clinical outcomes, instrumentation failure, and other problems with lack of fusion when you do these procedures. Okay, so in the old days, this was our biologics. The more bone, the better. Okay, so we've gone a long way from there, basic science and other things. One of the things I want to kind of point out in this talk is that things have changed over the years, going back to 1999. So I finished residency in 01, and back then almost everything was allograft bone and machine bone. So this is allograft bone and then machine bone. And really, that hasn't changed all that much over the past. This is up to 08, you know, but the trend is the same. This is the most recent article we find kind of detailing this. But what's really changed is growth factors in bone morphogenic protein. That's over the past, say, 8 years has skyrocketed once BMP was approved. So what are biologics now? We have more evidence on specific products. We're questioning the quality of evidence. There's this BMP controversy that I'm going to discuss. And there's a lack of evidence on certain things that we need to really focus on. So how do we choose the best options? We use peer-reviewed published literature. We use scientific data. We go to the internet and PubMed and look at different experiences. And then there's those of us who, bottom line, if you read this, I'm the one with the medical degree. I'll determine whether your back is bothering you or not. So, you know, that's kind of personal experience, you know, and I kind of try to shy away from that. You know, those of us that publish our data, you know, are shocked to really find out sometimes outcomes. You know, if you ask any surgeon, no matter what the kind of surgery they do, they're going to be biased towards better outcomes, you know. Ask them how many CSF leaks they get. Oh, I might get 1%. But then you go and look at their actual data, and maybe they're at 5% or higher. Across the board, non-unions, CSF leaks, bleeding. I mean, it's just a human tendency to underestimate your complications and overestimate your outcomes. So let's look at some of the data on these things. Platelet gels. Okay, if you go to the literature, really some of the platelet gels show inhibition of fusion. Okay, even though they're still in use. Okay, demineralized bone matrix. It's a $300 million market. Okay, yet there's almost no data to support their use. There's a lot of data in the literature, but it's very controversial, and there's really no solid evidence that it's really that good. Allograft and stem cells, pricing's high like bone morphogenic protein. There's really no great data. This is a slide out of a paper that their whole point of this slide, and I didn't want to make a big slide with too much information, but these are 3 different DBM, demineralized bone matrix products used for accessory bone fusion in when you do fusions. And as it shows the different products, okay, these people evaluated different products in a goat. I think it was a goat model. 60% fusion rate with one product, 0% fusion rate in another, 80% fusion rate in another. All of them are approved, and then they looked at the usage of these products They had absolutely no correlation with effectiveness. They correlated perfectly with the amount of money the companies spent to market them. It was amazing. So this is a bunch of preclinical data on DBMs, demineralized bone matrix, and there's some positive stuff, there's some negative stuff. There's minimal clinical evidence in humans. The bottom line is standard guidelines really don't exist for demineralized bone matrix in spine surgery, and there's differences in osteoconductivity and inconsistencies in fusion rates, and you may want to remember that towards the end. There might something hint. Okay, so stem cells. This is a totally different application to stem cells. Dr. Bullis knows a lot more about stem cells than I do, I admit it, but stem cells are an up-and-coming thing. There's a lot of questions. So when we look at stem cells, what are we thinking about with regards to fusions I'm talking about? You know, the ideal bone graft properties need to have three things. They need to be osteogenic, they need to be osteoinductive, and they need to be osteoconductive. Okay, autograft, when I say autograft, I mean like iliac crest bone graft is the ideal, the gold standard, because it has all three properties. The problem with it is there's a significant donor site morbidity. Anytime we take iliac crest bone graft, it adds at least an hour to the operation, significantly more blood loss, operative time, and risk of chronic pain. When I was a resident, that's all we did. We didn't use any demineralized bone matrix. We didn't use any. The BMP didn't exist. We didn't use any allograft. So we took hip graft on every single lumbar fusion and every single anterior cervical fusion. We took autograft. And I'll tell you, a lot of patients came back and they say, well, my neck pain's a lot better, but my hip now hurts way more than my neck did. So, you know, there's approximately, you look at the literature and it's kind of across the board, but I would say approximately 1/3 of patients that had iliac crest bone graft had chronic pain or other problems. You know, they can't wear a belt because it catches on that. And then there's the mesenchymal stem cells, osteogenic and osteoinductive. They're only osteoconductive if you're added a matrix to go with them. You might want to remember that too. So, looking at some of these stem cells, there is some data that the volume significantly improves efficacy. This just shows that in a study, 1 million culture cells had 0, 100 million had 71%, and then that's compared to iliac crest bone graft, and that was with the carrier matrix. This just is a slide that shows there's a lot of different potential sources for stem cells, cadaveric live, and then you go to the various different products that are available. There's really no great or really non-existent clinical data that these things really help with fusions. Okay, so in conclusion with regards to that, based on basic science and limited clinical data, level 4 evidence, which is not great, the use of mesenchymal stem cells can be a viable alternative, but there's a lot of unknowns. Standards of viability, effectiveness for fusion, whether there's a guaranteed population of cells, safety, cost effectiveness, all that stuff. So, BMP, okay? You know, there's a big controversy on BMP, and it's interesting. None of my partners, and really nobody I know, anybody I train with, takes iliac crest bone graft anymore because it's such a morbid procedure and it's limited and all the reasons I talked about. Pretty much everybody uses BMP. Okay, so you know, it's here. It's only approved for one specific surgery, and that is anterior lumbar interbody fusion with an LT cage. That's the only thing it's approved for. So, but if you look at BMP usage, okay, and this is actually a few years ago, 85% of its use is off-label. So we use it for posterior lumbar interbody fusions, T-lifts. We actually published at BNA the first paper in the world on transforaminal lumbar interbody fusion using BMP. A-lifts, cervical fusions, thoracolumbar fusions. It's used across the board. The problem is there's associated complications that really haven't been appreciated somewhat in the literature, but there's more. And sometimes part of the problem is you can do A-lifts, which is what it's approved for, and people can report retrograde ejaculation incidents, but unless you really know, unless you really test them for it, you don't know. So this can be up to 45% of men who have an anterior lumbar interbody fusion can have a retrograde ejaculation. So again, how is it defined? Self-reported, objective testing. Not many people really do objective testing, so verification is key. Okay, and this is a real article in a paper that kind of is kind of a funny way to really show that as an example. So it's a case in Germany, okay, the judge had to decide on, where a person and his wife, this is his wife, this is the person, wanted to have children, okay, and they tried and they couldn't have children, and all of us know that, you know, in vitro fertilization, all that stuff is inordinately expensive, okay, so her husband hired her neighbor, okay, who's married with 2 children, hired her neighbor to impregnate her, okay, so for 3 nights a week for like 6 months, he came over, and you know, he was paid $2,500 to do the job, right? Well, 6 months went by and she's not pregnant. So then he insists, you know, he's paying the money. He insists that he gets tested. Well, it turns out he's sterile. They didn't know because he'd never been objectively tested. Well, if you remember, he's married with children. Weren't his kids, which, yeah, disaster, stroke. So then the court case was actually her husband wanted his money back, and he said he didn't guarantee results. But so how'd you like that? You have somebody suing you for your money back, and that your children aren't yours. Anyway, okay, so verification is key. And the treatment is not so good. So this is a real issue. Okay, so the treatment for if you get retrograde ejaculation and you do want to have children, it's not a fun treatment. So looking at the results, the retrograde ejaculation results. So the issue is, okay, patients, if you do an anterior lumbar interbody fusion, is there a difference in retrograde ejaculation if you use BMP or not? Okay, that's the question. Okay, and a certain percentage of patients will get it regardless because you dissect the sympathetic plexus and stuff. But these are all papers that show, okay, if you use BMP, it's pretty significantly higher than no BMP. Okay, here's another complication. This is a 72-year-old man with who's profoundly myelopathic, progressive weakness, and he's got this MRI and CT scan. So he underwent a 3-level anterior cervical discectomy and fusion with the help of bone morphogenic protein, and his symptoms got dramatically better immediately following surgery. But then 3 or 4 days post-op, you can see he had massive soft tissue swelling with terrible hoarseness and dysphagia. And this was confirmed on CT scan, which you can see here. I'm not going to point it all out, but it confirms the significant swelling. And then this was in the early days of BMP, so it turned out that now it's considered contraindicated because of the high rate of swelling and dysphagia and other problems with anterior cervical fusion. Medtronic actually sent out a notification, you know, that it's contraindicated. We still use it once in a while in extremely high-risk patients because you have to weigh the risks and the benefits. If the risk of non-union is so high that it warrants the risk of this dysphagia and swelling, then we will still use, or I will. This was a paper on adverse effects associated with high-dose BMP, 151 consecutive patients, 23% complications, and this dose was used, and it's been shown pretty definitively that the higher the dose you use, the more likely you're going to get a fusion, but the more likely you're also going to have complications. There's other complications in addition to the soft tissue swelling, seromas, hematomas, osteolysis, other issues. This is a 59-year-old man who had an L2 to S1 fusion, who similarly did very well post-operatively, but then developed a terrible radiculitis that was associated with the seroma that was then drained with the CT needle aspiration, which significantly improved his symptoms. So the BMP causes a terrible, well, I shouldn't say terrible, a severe inflammatory response. Part of the bone healing process is inflammation. You can't really have bone fusion, bone healing without inflammation. So the problem is BMP is extremely powerful, and sometimes it causes too much, especially in these small spaces. It's been shown to occur in a lot of the minimally invasive procedures because you have such a small space and you get this reactive component. So there is some neurologic impairment with ectopic bone formation as well. That's a report of 5 cases. This is just demonstrates what can happen. So you do a T-lift and then the bone grows out into the foramen. When BMP first came out, Jeff Trayman, he used to be my original partner at BNA, we started using it. We were one of the first groups to use, like I said, the first published paper on BMP for transforaminal lumbar interbody fusion. I remember having a discussion with him. We had a really high-risk patient for a non-union. She was very osteoporotic, but would have been in a wheelchair if we didn't do the decompression and fusion. I said, I don't know, should we use this BMP stuff? It was one of the first ones, and he said, well, if, worst case scenario, she develops some bone, she develops too much bone, and we have to go back later and drill it out. But, I want to refuse. So, okay, so I didn't actually do the case. He did the case, and then he retired, and then the patient came back, and I had to go back and drill out all the bone. So it happens. Here's another report, 5 cases of ectopic bone formation, and this is another example of both ectopic bone formation and osteolysis within anaseroma in a patient. So osteolysis is transient bone remodeling from that can occur from the local concentration of the bone morphogenic protein. You can see that there. So the BMP was placed here, and then you get the osteolysis in the adjacent vertebral body, and this just shows really severe edema within the bone associated with that in a patient. So, all these complications were really, everything has complications, okay? So any surgery you do, there's a risk of complications. Anything you implant, any kind of drug, anything has potential risks and benefits. So, nobody really jumped up and down about all this stuff until recently. There was a paper that came out in the Spine Journal that said, well, we need to go back and look at industry-sponsored data. There was a review of the 13 original industry-sponsored data on the BMP product, and they found that the adverse events were kind of underreported, and some of the FDA documents revealed adverse events that weren't really shown, and these events can be increased. So there's a ton of controversy right now, and Medtronic actually really took an unprecedented step towards validating what was really true and right, and they funded a study. It's called the Yale University Open Data Access Project, and they cost them $2 million, and they basically hired 2 groups to go in, 2 independent review teams to go in and look at all of the data they could find on BMP. They concluded that BMP didn't really provide benefit over use of iliac crest bone graft and may be associated with potential complications, including cancer, possibly. But, like I said before, nobody uses iliac crest bone graft anymore, and practically everybody uses BMP. So this did not settle anything. They kind of looked at stuff and then compared iliac crest bone graft to BMP, but the morbidity associated, all of us that grew up in the iliac crest bone graft days, taking hip graft on every single patient, we know the morbidity associated with that, which is miserable, and it lengthens operative times, and it's horrible. I mean, sometimes we couldn't finish big cases because we were busy taking hip graft, and then the patient bled too much, and we have to close up, and these are big giant scoli cases, and we have to take them back, whereas if we had BMP, we could have finished the operation. So it's tough. I still use BMP. All of my partners use BMP. Pretty much everybody I know still uses BMP. The controversy is not settled. I think it's actually going to get bigger. When you look at all the data on the fusion rates, these are a bunch of papers, and the fusion rates are actually a little bit higher in the BMP group. Just looking at the total numbers, and when you look at cancer, it's interesting. Looked at again all those papers. There was a slightly increased rate of cancer associated with the BMP patients as opposed to the iliac crest bone graft, 20/8, and that was statistically significant. And the statistical significance went away at 4 years, so that's still also controversial. In conclusion, platelet gels inhibit growth. They're still used. There's really no data to support their use, but people use them. DBM, there's no standards or demineralized bone matrix. There's no standards or guidelines. There's differences in osteoconductivity. There's no great clinical data. Do I still use demineralized bone matrix? Yes, I do. I think it has a purpose. In certain cases, your choices, like doing an anterior cervical discectomy infusion, your choices are BMP, which has a known increased rate of complication, iliac crest bone graft, which I hate, and patients hate, or PEEK, or structural allograft. Okay, so I tend to use PEEK or structural allograft, which we're also doing a study on right now. But what happens when you get in there and you don't have enough bone to fill the allograft hole or the PEEK cage? Do you go to their hip for that little bit of increased bone? No. Do you take BMP for that little bit of, an increased risk of complications and a low-risk patient for a non-union? No. So you use DBM. I think, you got to weigh the risks and the benefits of everything. So even though there's no great solid clinical data, it has a role, in my opinion. Stem cells, feasible alternative, unknown standards and viability, clinical data on safety and effectiveness is really not there yet. BMP, we know BMP causes bone growth. I think everybody will agree on that. There's definite potential complications. It's associated with doses, and there is a limited use that should be in effect. I think the most important thing about BMP right now is that you have informed consent. You inform the patient, hey, there is a potential risk of increased cancer, but it's kind of like similar to using your cell phone. There's papers that show increased risk of getting acoustic neuromas and other brain tumors using your cell phone, and there's other papers that don't show it. There's possibly an increased use. Are you going to not use your cell phone because of that? No, you're not. You're still going to use the cell phone. So I'm still going to use BMP at this point for select cases. I think it's a good product in the appropriate patients. The future of biologics: optimize what we have, gather evidence on what works, minimize complications. In the Obama world, we have to look at cost effectiveness and that sort of thing. Questions? Okay. What would you use in a 70-year-old patient with a redo ACDF? Okay, so they had an anterior cervical discectomy infusion, cervical, okay, and they had a pseudoarthrosis, so they didn't heal, chronic pain, screws loosening. What would you use? Would you go to their hip, iliac crest, use BMP, use stem cell allograft, demineralized bone matrix, or other? Go ahead and start the timer. What would you use, Dr. Mason?
I would use DBM, actually, unless you have diabetes.
So DBM, BMP. Okay, so I think that's good. I definitely wouldn't use stem cells. There's absolutely no data to really support using it in that situation. Iliac crest, is an alternative. BMP, I would consider using BMP. DBM, it's interesting. Dr. Mason said he would use DBM. I would not use DBM. I would do other, actually. This is one of those questions that really doesn't have a right answer. So other meaning I would do an anterior posterior. Okay, well, I would educate the patient on the different risks. Probably the two I would use is either BMP, or I would say, do an anterior posterior, redo the anterior surgery with PEEK or allograft, and then just put some screws in the back and the neck, and then you lock them in. You're almost 100%. Nothing is 100%, but I've never had one of those cases, you know, go on to non-union. Okay, next case. Mesenchymal stem cells have the following ideal bone graft properties except. Go ahead, start the timer. This was one of the hints, so you guys should get this. That's correct. It's most of you got it correct. You have to, in order to use stem cells, have osteoconductivity, you have to use some sort of matrix, add an additional matrix. True, false. DBMs are the most extensively studied biologics, which demineralized bone matrix, which have scientifically robust data to support their use in spinal fusions. Go ahead and start the timer. Correct, that is false. That is false. Okay. So what is the reported percentage of BMP off-label use? Okay, the data that we have. Go ahead and start the timer. Correct. Most of you. Correct. 85%. I think it's higher now because that data was a little bit old. I think, you know, before those other papers actually came out, I think it's probably 95%. True, false. Transient bone remodeling, including osteolysis, is associated with high-dose BMP use. Go ahead. Start the timer. True. Yeah. Okay. Yes. Okay. Let's move on. Thank you very much.